I'm Colin Kerr and I'm reporting for Medical Update Online. Today I'm talking to Professor John Carey, who's a keynote speaker at the recent National Immunology Nurse Meeting held in Galway, Ireland. Hi John, it's very good to meet you.
You too. Good morning, Colin.
Thanks John. First of all, tell us a bit about the work you do.
So firstly, I suppose I'm a physician and I work in the west of Ireland in Galway University Hospital, and I specialise in rheumatology and I have subspecialty expertise in osteoporosis and bone disease. And part of my work, 1/3 of my work, is dedicated to academic work at the university. And in that role, I'm primarily engaged in research and undergraduate and postgraduate education. In my clinical work as a rheumatology specialist, I see general rheumatology patients, and I also run the osteoporosis, fracture liaison service and DEXA services for the hospital here in Galway. And I teach and train people on osteoporosis and DEXA around the world.
So let's move on to the Galway meeting, where you're talking about skin and bones. And at that meeting, you reviewed similarities between skin and bone, including the amount of type 1 collagen in both. Let's talk about current best practice for assessing bone health and fracture risk.
Sure. So today, there's a few key concepts people need to understand at a basic level because there's a lot of confusion out there. The first concept is osteoporosis is the disease. The second concept is the test is a DEXA scan. The third concept is the consequence of osteoporosis is skeletal failure. And the fourth major thing that people need to know is fractures are the clinical events that occur, and a fracture is a broken bone. So the first thing, the best practice is to identify people for primary prevention before a fracture occurs. And to do that, we have a number of tools at our disposal. The best tool is a DEXA scan, and DEXA measures bone mineral density. And you can use that in combination with other factors like age, our family history of osteoporosis, to identify people who are at higher risk of fracture. The next thing, I suppose, is, and this is a huge pet peeve of mine, that once you've had the fragility fracture, you now have osteoporosis. It's like having a heart attack. You have the disease once you have the events. Unfortunately, some people still think that you use the DEXA to make the diagnosis, but that's a myth that needs to be erased. Once you have the fractures, you could still have normal bone density, or you could have low bone density that's not at the osteoporosis level. But once you have the fractures, you have the disease. So in scientific terms, that's called a false negative test. Just like people have COVID, if 10 people have COVID with the PCR test, about 6 out of the 10 test positive. That means 4 people will have a negative test, or false negative test. So that is the basis for a simple understanding of who's at risk and how to make a diagnosis. The next thing that's really important is once the diagnosis is made, we do a more holistic assessment of the patient to see what their prognosis is like, who's more likely to fracture or less likely to fracture in future, what other risk factors they have that we could modify, such as fall prevention or changing some medications they're on, and finally then osteoporosis medications. Unfortunately, in Ireland, as we reviewed at the conference, less than 20% of men and women over 50 who are admitted to public hospitals in Ireland leave the hospital with a diagnosis of osteoporosis. So that's a major failure. 80% or more are not even diagnosed with the correct disease. Unfortunately, that means several things don't happen. The patients aren't aware they have it. The doctors who don't work with them in the hospital aren't aware they have it. They're less likely to be tested, and they're less likely to be diagnosed and less likely to be treated. And unfortunately, that group is the high-risk group who are much more likely to end up back in the hospital again with another fracture, and it's also the most expensive group to manage.
Okay.
So standards would say when you leave the hospital, you leave with the treatment, you leave with the diagnosis, and you leave with a good follow-up plan.